Good evening, everyone. First case, a 25-year-old male presented with diminution of vision in both eyes for the past 6 months. He was treated elsewhere as bilateral panuveitis. He was on treatment with immunosuppression. Past systemic history was non-contributory and lab workup was negative. On examination, the best corrected visual acuity in right eye was 6 by 9 N6. There was cells in anterior and anterior chamber and vitreous. Left eye, the vision was 6 by 12 N6. There was AC reaction in cells in anterior vitreous. This is the fundus photo of the right eye. There is disc hyperemic and choroidal folds and depigmented fundus. Fundus photo of the left eye. There is hyperemic disc and choroidal folds and depigmented fundus and mid periphery changes. The OCT in the right eye, you can see SRF, choroidal folds, and thickened chloride. In the left eye, we can see with cells, RP alterations, and subretinal fluid. In the early phase in the right eye, the FFA shows early hyperfluorescence leaks with the hyperfluorescent areas. The ICG shows choroidal hyperfluorescence with hyperfluorescent dark dots. This is because there's of inflammatory foci. In the left eye early phase, the FFA shows mixed hyperfluorescent and hyperfluorescent patches. In ICG, you have choroidal hyperfluorescence and choroidal vessels, which margins are fuzzy, and you have hyperfluorescent dark dots. In the mid phase of right eye, uh, there is increasing hyperfluorescent pinpoint leaks, and there is disc leakage. In the left eye, there is progressive leaky choroidal vessels seen by the hypocynescence, and there is a hyperfluorescent dark dot. In the left eye, early mid phase, we can see disc leakage, and there is a mixture of increasing hyperfluorescent and hypofluorescent spots. And in the left eye, we see increasing choroidal hyperfluorescence and HDD spots, and there is fuzzy choroidal vessels. In the late phase of the right eye, we can see disc leak and hyperfluorescent leak. It shows there is a collection of subretinal fluid. And in the ICG, you can see increasing choroidal hyperfluorescence, which is indicative of the increased choroidal vessel leakage. And the hyperfluorescent dark dots it indicates a full thickness lesion. And there's disc leak. If there's disc leak in late phase, it indicates severe inflammation. In the late phase of left eye, we can see disc leak and increasing hyper with hyperfluorescent spots, which is indicative of RP atrophy changes. And then ICG, we can see HDD spots. This is also persisting till late phase. This is full thickness lesion. Then you have choroidal hyperfluorescence indicating leakage. So the diagnosis resolving VKH. He was treated on immunosuppressions.
So this is a case of VKH and ICGA is very characteristic in this last case. So in the early phase of ICG, we could see the choroidal hyperfluorescence. This choroidal hyperfluorescence is because of leaky choroidal vessels. Because in inflammation, there can be formation of leaky choroidal vessels, and it can cause choroidal hyperfluorescence in earlier phase of ICG. Then in the early and mid phase, we can see the fuzzy choroidal vessels, as Priyadharshini, fuzzy choroidal vessels and disc hyperfluorescence. Usually in ICG, we saw the disc hyperfluorescence. This disc will be black. But in case of inflammatory disease in VKH, we will see that fuzzy choroidal vessels along with disc hyperfluorescence. And another one finding which we usually saw in the mid to late phase is the hyperfluorescent dark dots. So with choroidal hyperfluorescence, which was seen in the choroidal hyperfluorescence, whichever is seen in the early phase, along with disc hyperfluorescence, which was seen in the mid to late phase, is the signs of acute VKH. But in case of usually old VKH but chronic VKH, we could see the hyperfluorescent dark dots, which was seen mostly in the mid to late phase, and fuzzy choroidal vessels is more than the other two finding, like choroidal hyperfluorescence and uh, disc hyperfluorescence. The hypofluorescent dark dots and the fuzzy choroidal vessels will be more in case of chronic VKH cases.
So in ICG, the VKH signs, in VKH, the ICG signs will be there is early hyperfluorescent leaking choroidal vessels, there is hyperfluorescent dark dots, there's loss of normal vascular pattern indicate with marked by indistinct fuzzy stromal vessels, and there is disc hyperfluorescence. In FFA, in acute stage, there is serious exudative detachment, which is shown by multifocal hyperfluorescent pinpoint leaking points, and there is late pooling of the dye. There is also optic disc staining and leakage. In the chronic stage, there is a mixture of window and masking effects because of the diffuse RPE alterations. This is because the exudative RD is settling, the limits of which is marked by high watermarks. So in acute phase, FFA, there is pinpoint leaks, and in late phase, there is pooling of dye. In the chronic phase, in FFA, only the hot disk can be seen, but in ICG, we can see subclinical hypersenescent choroidal granuloma, which is indicator of the activity of the disease. A 50-year-old female presented with blurring of vision in right eye. She was treated in left eye with serpiginous choroiditis 1 year back. Uh, in right eye, the visual acuity was 6 by 18 N18, and there was cells in anterior vitreous phase. Left eye, the vision was 6 N6, and there was cells in anterior vitreous phase. The fundus photo of the right eye shows ill-defined choroidal lesions with the creeping margins. It's indicative of serpiginous choroiditis. And left eye, there is there is well-defined choroidal lesion with the underlying chorioretinal atrophy. The fundus autofluorescence of the right eye, we can see with hyper autofluorescent borders, which is indicative of activity. And in the left eye, there is hyper autofluorescent, which is indicative of inactivity. The In the right eye, the early phase, we can see in FFA, we can see hyperfluorescent patch. In the mid phase, there is hyperfluorescent with increasing periregional hyperfluorescence. In ICG, in early phase, we can see hypocynoscent patches, and there is surrounding perilesional hypercynosins, and and in the mid phase also we can see hypercynosine spots with the surrounding perilesional hypercynosins. In the right eye, in the late mid phase, we can see in FFA there is increasing hyperfluorescent patch with perilesional hyperfluorescence. Also in the late phase, in the ICG, there is in mid phase and late phase there is hypocynosins and increasing perilesional hypercynosins. So in ICJ, the activity is indicated by hyperfluorescent areas that goes beyond the lesions with the diffuse perilesional hyperfluorescence, which is not seen on FFA. And in FFA, the active phase is there is faint late hyperfluorescence, which is seen as hypocynosine patches in the ICGA. The FFA of left eye shows there is hyperfluorescent staining in all the phases, which is the indicator of inactivity. And in the ICG, you can see hypocyanescent patches, but with underlying choroidal vessels, which is indicative of inactivity and showing the underlying chorioretinal atrophy.
Yes, 1 minute. So in this patient, the right eye has the active disease, but left eye has the healed choroiditis patch. So how to differentiate in FFA? So in the right eye, as we have seen already, first is hypofluorescence, and then hypofluorescence along with border will be hyperfluorescent. But in case of healed choroiditis patch, the earlier phase there will be hypofluorescence. This hypofluorescence, the causes are different. This is because of RP cell destructions and RP hyperplasia. It will cause the blocked fluorescence, and it causes hypofluorescence in the early phase in case of healed choroiditis. But in the late phase, we'll see the hyperfluorescence. This is because of staining. Staining means because of the RP damage, the late phase there we can see the staining, and it causes hyperfluorescence in the late phase. So the hyperfluorescence in the early phase in case of active choroiditis and hypofluorescence in case of heel choroiditis, the causes are different in the early phase.
If you see this, so you see the images there on the top and the left last, sorry, on the right hand side, you will see that there is staining more in the edges there in the FFA than in the center. That's because there is no choriocapillaries there in the center. So the disease in the center is the most what you call choriocapillaries destroyed most in the center, which is how your serpiginous choroiditis behaves. The central edema that you see is basically there is choriocapillaries damage. Surrounding choriocapillaries is still surviving. But if you look at the first picture before that, the early phases, the active disease, you can see the size of the lesion. The whole size of the lesion is equivalent to the whole size of the lesion on ICG, the dark.
Yes.
ICG actually tells you the true size of the lesion, whereas the FFA will just tell you the central area is more involved because it's damaged. There is no, the choriocapillaries, one is choriocapillaries either ischemic or the overlying RP is edematous. So you can't see the the choriocapillaries. FFA shows choriocapillaries, their activity covered by the RP. So if the RP is healthy or RP is hyper, you might not see the choriocapillaries very well. So this is what is happening. But at the edges, the choriocapillaries is still visible. It's leaking, but ICG will not show choriocapillaries leakage. You see the whole size is equivalent to the size of the whole ring. So ICG is a true indication of the size of the disease, the effect. But there are different reasons why the the ring is there in the FFA, whereas the center. So the disease spreads from one location and goes outwards. But if you see the late phase, it tells you the disease, exactly what happens. Go to the next slide. So now if you see on the right hand side image, the central area next to the disc is dark because there's no choriocapillaries to leak fluorescein, but the edges will have. So there are surviving choriocapillaries at the edges. And that's why you're able to see the stain more in the periphery rather than the center. So the center, there's hardly any choriocapillaries. It's a dead area. Whereas ICG just shows nothing but the vessels below. The choroidal vessels are not affected, the large choroidal vessels in serpiginous. So you might not see anything there. It just goes to tell you the whole area where the overlying RP is gone. So two things you can see, RP and choriocapillaries health, the late phases.
So the right eye was active multifocal serpiginous choroiditis, left eye was heel choroiditis. 42-year-old female, she had complaints of redness and blurring of vision in the right eye for past 1 year. She was diagnosed as SLE 4 months ago. Her double-stranded DNA was positive and ANA was positive. She is a known diabetes and hypertension patient under treatment. There's family history of SLE and breast carcinoma. The vision in right eye was 6 by 7.5 N6. Uh, AC was squared. Left eye vision was 6 N6 and AC was squared. The fundus photo of the right eye shows ill-defined choroidal lesions, and left eye also shows ill-defined choroidal lesions. In the right eye, in the right eye, the hypo that in all the phases of ICG we can see hypocynosine patches, whereas in FFA in all the phase we can see increasing stipple hypofluorescence. In the uh, in the left eye, the ICG shows persistent hypocynosine patches, and in FFA we can see increasing stipple hypofluorescence. These patches show there is choroidal activity, that is a diagnosis of SLE choroidopathy was made. Because there was breast carcinoma history, we did the MRI brain and orbit, which was normal, and the patient is currently on treatment with immunosuppressions. The ICG is helpful mainly in recurrent VKH where there's only AC reaction. The ICG will pick up the hypocynosine choroidal granulomas. In choroiditis and FFA, the late leakage only there will be activity, whereas in ICG it is showed by hypocynosins with perilesional hypocynosins. In SLE choroidopathy, there is hypocynous patches throughout, which can be the initial presenting symptom. Thank you. These are my acknowledgements, and thank you.